Good afternoon, everyone. It's my great pleasure to be here. I will thank for the CML Horizons and my patient Zheng Chen. He recommended me to be here to give the presentation. And I know Zheng Chen is before 10 years, and at that time, he was looking for the donors for transplant. Now he does not need transplant. And my topic is about transplant. Today's role of transplant in CML, only for the blastic crisis or earlier. How to, No. Following the instruction of TKIs, the numbers of the patients receiving transplant decreased, and the transplant shifted from a preferred first-line therapy to a second, third, or the first-line option, just like Dr. Neusha and Dr. Saglio showed the guidelines from ELN and NCCN. But this transplantation is reserved for the patients with insufficient TKI responses or in the patients with advanced phase. But it is noted that transplant is still the only treatment that can ensure a true cure for the patients, despite a low numbers of the patients undergoing transplant nowadays. And this is the data from Hammersmith, and during the past 30 years, the survival of the disease phase and the decay of the transplant in the patients with CML. We can see the patients in the first chronic phase, half of them alive, and one-third of the patient in the accelerated phase alive. And the patients in the first chronic phase significantly improved in the 1990s compared to the last decades. And according to the ELN recommendation and the NCCN guidelines, transplant is recommended in the blast phase at diagnosis or whom progressed to BP after TKI treatment, provided that a remission has been included and the transplant in full BP is usually effective. But in the accelerated phase, the patients at diagnosis is not achieving an optimal response to the first-line TKI or who progressed to accelerate phase after TKI treatment are recommended to receive transplant. For the patients in chronic phase who failed 2 TKIs and do not achieve an optimal response to the third-line TKI, and another situation for the selected chronic phase patients who have high-risk characteristics, failed the first TKI, and do not achieve optimal response to the second-line TKI were recommended. And this is but some opinions from the transplant doctors, just like the indications for transplant from Hammersmith. We can see the indications, most of them are similar, but with minimal difference. We can see the similar is for the blast crisis. As soon as possible after re-establishing chronic phase with TKI or chemo. And in the accelerated, we can see two kinds of patients. Less advanced accelerated phase at diagnosis treated as the first chronic phase. and near to blast phase or evolution into AP on the TKI. So we can see the two kinds of patients with different treatment recommendation. And the first chronic phase, failure of available TKI. And maybe this is, it has two meanings. First is in some countries we only have 2 or 3 TKIs, but in other countries, in the developing countries, maybe ponatinib, pazopanib are available, but such as in China, we only have 3 kinds of TKIs: nilotinib, dasatinib, and imatinib. So the available TKI are different in different countries. And another meaning maybe some patients cannot afford for the high cost of the long-term TKI, long-term treatment of TKI, especially for the second generation TKI or the third line or the third generation TKI. So failure of available TKI maybe is a best option for the first chronic phase patients. And the patients failed and the T315I mutation. Because in China, this is the national insurance coverage of CML therapy by 2030. In China, hydroxyurea, interferon, and transplant are covered, but TKI are not. So the patients should pay more money for their TKI therapy. So patients receive the transplant, we can see the cost is lower than continuing treatment of TKI. So in our hospital, in our hospital, because my center is famous for transplant, we perform several comparative study of the comparison TKI and transplant. This is an example. This is the comparison between TKI versus transplant in the patients in a BP phase. So you can see this transplant was significantly superior to TKI, has high PFS and OS rate. This is in the blastocrisis. And in the accelerated phase, this is a report from Abdi Anderson, and the conclusion is TKI should be considered standard initial therapy for the patients with accelerated phase at the time of diagnosis, because the result is similar to the patients in chronic phase with TKI treatment. And this is our data, imatinib versus transplant for previously imatinib untreated accelerated phase patient. We can see, this is result. This is a comparison of the PFS and the OS, and the patient received the transplant had a good outcome compared to with the patient in imatinib group. We find adverse prognosis factors prior to treatment for the both PFS and OS, CML duration more than 1 year, and anemia and the peripheral blast. So we can group the patients into 3 cohorts: low risk, intermediate risk, and high risk. We can see in the low risk AP patients the similar response, the similar outcome, but in the intermediate and the high risk AP patients, transplant was significantly superior to imatinib. So This is this is evidence to support the patients with less advanced AP may be benefit with a TKI treatment, but patients in intermediate or high risk will be benefit with the transplant treatment. This is another study about patients in chronic phase, the first chronic phase, less than 1 year after diagnosis. More than 300 patients in our center to compare the two treatments. All these treatment, one arm is received imatinib, one arm eligible for transplant with actually identical simply transplant. So we can see the outcome in the imatinib treatment, in the imatinib group, and the PFS and OS are superior, and no 5-year treatment-related morbidity in the imatinib cohort compared to 17% of the patients in the transplant cohort. And the progression rate is similar. And the more patient in the transplant groups has MMR and CMR response. And we compared health-related quality of life for the patients in the first chronic phase. And this is the number of patients. The median follow-up is 44 months and nearly 5 years in the transplant. So we can see the patients had a similar QROL. The similar to quality of life. So my conclusion is transplant is no longer the first front choice for newly diagnosed CML in the first CP. The management of CML still require the use of transplant, even if only a minority of the patient who is in advanced phase or do not respond appropriate to available TKI, as well as those with limited financial resource. Less advanced or low-risk AP should be treated as CP. Proceeding with transplant is a complex decision. Each patient requires ongoing risk-benefit analysis for the optimal timing of the intervention. And thank you for my patience and the New Sunshine Charity Foundation and the CML Horizons. Thank you for the attention.
There's a question from Ferdinand.
Yes, I have a question. Thank you, Qian. My name is Ferdinand. I'd like to know, why is transplant still very expensive, despite the fact that TKIs are doing a better job? And how much would a transplant be today?
Because transplant in China is covered by the insurance and TKI not. So in China, before several years ago, most of patients in the first chronic phase prefer to receive the one-time treatment, not a lifelong treatment of TKI. But now, our experience and our study results has supported the most important evidence to support guidelines, NCCN and ELN guidelines for imatinib will be the first option for all patients in the chronic phase. So we educate the patients to receive TKI, even though it's a high cost.
My question is to Dr. Jiang also. I must admit that I was very surprised to see one of your slides stating that the quality of life of patients treated by imatinib is worse than the patient's quality of life of patients undergoing transplant. And from our own experience, when I see our patients having a lot of side effects on imatinib, but most of them are tolerable, when I see patients going transplant and fighting the GVHD, it seems to be that the quality of life is much worse for them. So how can you explain this slide?
I think a great question, because this is a survey from the patient survival with long survival, more than in the imatinib group, more than 3 years, and in the transplant group, nearly 5 years. So all these patients has been alive for a long time post-transplant. So they have a similar quality of life. The patients in the early phase post-transplant maybe experience GVHD, chronic or acute. They have a poor quality of life. But all these patients answer the questions has a long-term post-transplant. So this is the result. Thank you.